All right. Well, good afternoon, everyone. My name is Dr. Tracy Newman, and I am a pediatrician and the medical director here at the North Dakota State University Center for Immunization Research and Education. Today, I have the pleasure to introduce Patsy Stinchfield, who will be presenting this webinar titled 2026 Measles Outbreak: How did we get here and how do we get out of this? Patsy has been in the nursing profession for 48 years, with 34 years as a pediatric nurse practitioner, specializing in vaccine preventable diseases, infection prevention, and vaccine communication. She is currently an independent consultant after finishing a 34-year career as Senior Director of Infection Prevention and Control at Children's Minnesota, leading the award-winning Children's Immunization Project and guiding the organization through major outbreaks, including measles, H1N1, and COVID-19. Patsy has held leadership roles with the National Foundation for Infectious Diseases, the CDC's Advisory Committee on Immunization Practices, and National Association of Pediatric Nurse Practitioners. She is a frequent national and international speaker, advisor to the Vaccine Integrity Project through the University of Minnesota's Center for Infectious Disease Research and Practice, and has been interviewed extensively by major media outlets on vaccines and outbreak response. She holds a BS in nursing from Minnesota State University Moorhead and an MS in nursing from the University of Utah, and has received numerous awards for her contributions to immunization and public health leadership. Patsy, welcome. You can begin.
Great. Thank you so much, Dr. Newman. And thank you to everyone who have invited me today. I appreciate all the support to this point from the Center for Immunization Research and Education. So, measles. Oh, it's sad we're having to talk about this, but we need to. Where are we in 2026 and where are we going? I don't have anything to disclose as far as any conflicts. And you got the objectives here. We're going to talk about where we're at with measles, some hotspots, and review some of the clinical and medical management, including vitamin A. We'll talk a little bit about immune globulin, quite a bit about infection control in healthcare settings, and then some tips on communicating. So I'm really excited today because I'm going to be sharing some things with all of you that no one has heard yet. Last week, well, May 7th and 8th, there was a National Measles Summit convened by the National Foundation for Infectious Disease, which I'm the immediate past president of, and funded by the Infectious Disease Society of America. There were 15 different professional societies represented, including the Pharmacists Association, NAPNAP, the Nurse Practitioners, American Academy of Pediatrics, school nurses, the Council of State Territorial Epidemiologists, some other public health entities. It was basically an invitation only of 70 measles geeks like me who are experts in the United States. And we had different work groups and subcommittees. There was one just on neurological aspects, on how measles impacts the brain and can impact your life because of the impact it does to the nervous system. There was a group on communications. There was a group on public health, contact tracing, and things that where are our gaps and things we need to work on there. There was one on immunology and what do we know about this whole immune amnesia. I led the section on infection control. So you will note in the slides, I'm bringing some of those conversations directly to you. And in a few months, I don't know when, but we will be writing up all of the learnings from being 2 days in a windowless room together, talking about where are the gaps in measles care, what is some of the research we need to be doing, what do we know are solid evidence-based things to do. And so keep your eye out for that. It will be coming out through different professional societies, like I said. But here we go. I'm going to include some of that as we talk. Let's start off with where are we with our measles epidemiology. So this is a US map currently of our measles cases. You can see that dark blue is 500 plus cases. We want this map to be gray, 0 cases across the United States. And you can see the majority of states do have some measles cases right now. This I printed when my slides were due May 12th. And you can see here, this is from the Johns Hopkins Measles Tracker. I really find this to be a reliable source I checked it this morning, and we're now over, unfortunately, 2,000 cases. We have 2,006 measles cases in the US right now. So we're about to reach a recent, well, 30-year ago record on the pace that we're on right now. You can see from this the bubbles, the size of the bubbles matter. In South Carolina, that 600 plus cases there. Utah has really more cases, but you can see it spread out throughout the whole state. I was told that every county in the state of Utah now has a measles case. And interestingly, these states have gotten there in different ways. So if you look at the top two, South Carolina, they had no cases, no cases, no cases. And I feel so sorry for those people there. Look at that in December and January, it just went straight up. And so those hospitals and public health were just overwhelmed. Whereas Texas, the second highest, started way back on February 2025 and sort of this slow high growth. But no matter how you get there, dealing with even one case of measles in a state, whether you're on the public health side or in a clinic or a hospital, is considered an emergency and is a lot of work. I've been through many measles outbreaks, and I feel for people going through this now. Well, where have we come from overall? If you look at that top graph, so this graph starts in 1962. I was born in 1958, which is not on here, but that was the highest year of measles cases with 800,000 cases in the United States, 550 deaths. And so this is pre-vaccine. And you can see the note there in 1963, the vaccine was licensed and introduced. We do not want to go back to those kinds of numbers. And we can go back. If we don't have a vaccinated population, we very well could go back to losing hundreds of kids from measles. And so the vaccine introduced, you can see there in 1963, it really did a marvelous job in bringing down the cases. And then the next little blip there was where I, as a brand new nurse practitioner, right out of school, started managing measles. 1989, 90, 91 was a 3-year measles outbreak. In my state of Minnesota, we had 440 cases and 3 children died, and it really changed the course of my career and got me into vaccines. Like, how can children die of a vaccine preventable disease? It was so sad. And what we realize is that that number there, in that where it says second dose was recommended, that was 1990. The 1991 cases were 2021 that year. So we're now in 2026 at 2006 cases. We are probably going to surpass the last highest number of measles cases in 30 years, at the rate that we're going right now. If you go to the lower graph there, you can see in the far right is where we are right now, 2026, approaching what all of 2025 number of cases were. So we are going to surpass last year, and we will probably even surpass the 1991. So we're going backwards. It's really very concerning for all of us. And why is this happening? Well, it's pretty simple. I think you all know that it's because our MMR vaccination rates are dropping. This whole map should be teal, which is 95% or greater percent vaccinated for kindergarten entry. And you can see we don't have very, you can count on 1 to 2 hands here how many teal states, which is in good order, 95 plus. Those with less than 90%, including my own state of Minnesota, Idaho, Utah, Arizona, these states are very, very much at risk. So that is actually end of story. This is what we have to work on, is get those vaccination rates up across the country. And why are they so low? Well, one of the biggest reasons is there's many reasons. There's many, many reasons, but one of the biggest reasons is the exemption rate. So if you look at that green line across the bottom, that is medical exemption. So a child with an immune deficiency should not get a measles, mumps, rubella vaccine because it's a live vaccine. They have a true contraindication for it. And you can see that hasn't budged in years because true contraindications are uncommon, and they really don't change too much with the population or with medical interventions. Whereas these other two lines are measles exemptions for non-medical reasons. The pink one is, the blue one is just all exemptions. And this I got from the CDC School Vax View Interactive. It's a very cool site. You can click on these different buttons, look at data. If you just want to look at one particular vaccine, or if you want to look at other kinds of indicators together, years, for example, it can give you a lot of good data. But the number of exemptions that is being allowed in states and schools is part of the problem. We'll talk more about the other parts in a bit here. So this came from Dr. Dan Filardo from the CDC Measles group. He was able to join our Measles Summit and was wonderful having, what did we have? 4 CDC folks there, and we gave them a standing ovation for their hard work and situation they're in right now. But what they've looked at in the trend so far this year, what's going on with measles, it's pretty similar to other years in terms of the clinical presentation. So main complications, diarrhea, otitis media, pneumonia, encephalitis. Virtually everybody who gets measles will have some immune amnesia. We had Dr. Michael Minna originally from Harvard, who was the person who published about immune amnesia and coined that term. He was at the summit and basically said, the kids that are the youngest and the sickest with measles will have the greatest immune amnesia. That is the loss of antibodies that you have collected through vaccination or through infection. It can be up to losing 73% of that immune memory. So that is a significant thing. And we're setting up some ideas about how do we track these kids who get measles, and then what are they getting afterwards? Are they getting pneumococcal sepsis? Are they getting more otitis media? Trying to see if there's a way that we can actually measure. It's not just measles that MMR prevents, it's other diseases that will come after that case if you don't get vaccinated. We've had 3 deaths this year, 1 adult and 2 children so far. And we're worried that we're going to see SSPE, which is subacute sclerosing panencephalitis. To me, this is just one of the most horrific outcomes of measles, where it gets into your brain, the virus gets into your brain and settles there. And much like shingles with chickenpox, which will come out later and develop a rash on your body through your nervous system, measles goes into your nervous system, gets into your brain, and over 7 to 10 years will just slowly deteriorate your brain, so that at first it's sort of behavior problems, then you lose speech, then you lose the ability to feed yourself, to walk, to talk, and eventually they die. It's fatal. And that is about 1 in 600 people who are infected under the age of 1 will get SSPE. So it's far more common than we thought. And we're very concerned we're going to probably see more of this in the next decade because of the number of cases we have right now. We're also seeing in 2026 on the older side, older non-vaccinated kids, indicating that this lack of vaccination has been going on a while. And one of the biggest keys, as we see in almost every outbreak, is that it's the unvaccinated who are infected, 92%. So our key takeaways is that this epidemic has shifted across the Americas. We had people from Mexico and Canada there who both have significant outbreaks, and Mexico has seen quite a few deaths, about 35 deaths. Canada has seen some terrible congenital measles births from unvaccinated moms getting measles while pregnant. And these outbreak trends are really concerning. They're larger outbreaks, they're more frequent, less imported cases. These are now cases that are coming from within the individual countries. And they're less geographically contained, as you saw from that original map. And one of the biggest issues is around trust. There's less public trust. So we have to just think about it worldwide. Measles anywhere is a risk everywhere, and we need to increase our vaccine coverage as much as we can. So, what works to reduce our outbreaks? This is from a paper I wrote with a colleague a few years ago, and we know that if you vaccinate on schedule, that you'll reduce your chances of infection. The more you delay, the greater your risk of getting sick. Reducing those exemptions, really working on school entry requirements, state laws around that. We don't use the M word because nobody wants to have things mandated, but school entry requirements they work. They really work to get kids vaccinated and not spreading it in schools. But it's not just, people who are anti-vaccine or have been victims of mis or disinformation. There are some people that are just behind. They're behind from the COVID pandemic. And we know that there's some clinic practices that can help. Like, do you have a reminder recall system? Do you text your patients and have them come in? Do you have your staff know that every visit is a vaccine visit so that you've got a broken thumb, you go to the doctor, you get your thumb looked at, taken care of, and your vaccine schedule looked at and taken care of as well. We want to make sure that we have easy access, some nurse only visits, walk in visits, and the importance of the school nurse. I mean, talk about a trusting, well known relationship. We really need to make sure that we're enhancing that relationship and conversations between the school nurse and any hesitant parents or kids that are behind. We want to listen first in all of these vaccine communications and just find out where their concerns are coming from. Because it's multi reasons. Like I said, it's not just one issue of why we're behind on MMR vaccine and why we have this outbreak. It's multi reasons, and so it's going to take multiple solutions. We have to use presumptive communication, which is as they come into a clinic, that I presume that you want to follow the things that I'm going to recommend today. I'm going to listen to your concerns. And so you start the conversation of today, your child is 12 months old. So we're going to do the vaccines, varicella and measles, mumps, rubella, et cetera, et cetera. That's on the schedule for this age group. What questions do you have about that? So you're presuming that they're there to get vaccinated versus starting open-ended, like, well, what do you believe in vaccines, or what are your thoughts about vaccines? That does not instill trust. So you want to make sure they're using the presumptive method. Okay, so let's dive into some clinical aspects of measles. And I'm going to talk about this from my firsthand experience with our 2017 measles outbreak in Minnesota that impacted primarily the Somali preschool community. This is one of our patients. Their parents allowed us to take their photos and to use it for things like this, educational purposes that I would be talking, but we won't be able to share this photo with you in the future slides because they wanted me to be the one to be the presenter of it. So, but look at this little kiddo, very classic. Here's how it usually starts. A child comes to the ER, 2 years old, 4-day history of fever, cough, congestion, a rash started the day prior, no travel history, no MMR vaccine, was diagnosed, so was in a clinical setting 5 days prior, otitis media, was started on amoxicillin. So, oh, let's see, this maybe could look like an amoxicillin rash. They haven't traveled, no known exposure. And so the answers are no, no, no in terms of measles risk. But the hospitalist says this is probably a rash from the amoxicillin and the suspicion for measles is low. Well, in fact, as they were talking to fellow residents, there was another child who got admitted from a daycare, and we found who was positive for measles and found out that that child was his best friend. And pretty soon we realized we have an emerging measles outbreak. So what do you do at that point? You really get into all hands on deck. You start to work with your communications department, get measles alerts like this posted, printed. So much of what I'm talking about, I really hope you already have done or that you can do in advance so that you're not doing this while you have your first few cases of measles. You don't want to build the plane and fly it at the same time because it's really, really hard. So you want to make sure that you're doing screening tools, which I'll show you what we've used without a history of travel. I think sometimes we thought only about imported cases, but we've got to set that in the background because now there's so much measles in the United States that a history of travel is really irrelevant. You want to make sure that your vaccine registry is active. And we pulled our Minnesota Department of Health registry right into our children's hospital electronic medical record. So the staff didn't have to go back and forth between two systems. And so it was just a tab within our EMR that made a huge difference. Really helpful. We implemented universal masking so that, rather than trying to figure out who is infectious, who isn't, as you enter the hospital for your protection and everyone else's, we're going to have everyone wear a mask. That helped a lot. We moved our emergency triage to the outside. It was April, so we could do that in Minnesota, and had a pivot nurse. In Texas, they talked about the shed that they built outside of their children's hospital there and did their assessment and had their risk management people consider that part of the ER. So they were still meeting EMTALA laws, some of the things you have to think about. And then really looking at your AII rooms, your airborne infectious isolation rooms, which are negative airflow rooms, immediately rooming people into that. Do you have enough of them? Is another question. So again, we developed a screening process. We took out the whole international travel business. Have they been exposed to measles? What do they have a fever and a rash? And it kind of gets you to helping narrow down your population. Well, this particular outbreak, we had 75 total cases, and 53 of them were managed by Children's Minnesota, where I worked. The average age was 3 years old, and 21 of them got hospitalized, 100% at Children's Hospital. Um, One child was readmitted with pneumonia, and the average length of stay was about 4 days. Most of them were admitted for IV fluids. They were very dehydrated, not eating, not drinking, miserable, miserable kids. So, one of the most important things is, can you recognize the rash right away? Because before the rash, they look like every other kid with a runny nose and cough and feeling yucky. But these are three different rashes. I want you to pick which one you think is measles, because only one is. And based on stories, you can get confused and say, well, I did a strep test and they were strep positive, so maybe it's a strep rash. Or we, like the last kid I just talked about, he had otitis media, gave him amoxicillin, he developed a rash. Well, it's probably a penicillin rash. They do look alike. So pick your rash, which one is measles? Let's take a look. This first one is, in fact, an amoxicillin allergy rash. But again, it's covering the whole body and can be sort of this head to toe kind of rash. The one on the right is a strep rash. Again, that looking kind of confluent maculopapular rash, but the one in the middle is a measles rash. So this is one of our biggest problems. And because we have young parents and young clinicians, many of whom have never seen measles. So this kiddo on the far left, I would say, no way does that child have measles because he's smiling and his mouth is nice and moist. You don't get to the advantage of the other faces, but the rash is just one thing. And it's also just sort of how miserable they look. These are not kids that are goofing around in the room or asking for a popsicle. They are asking you to turn the lights off, and they're flopped over their parent's shoulder like this child. Now, the rash is a little bit harder to see in darker skinned kids, but you want to start in that hairline, like this kiddo on the right, and actually almost feel for the rash. This was very prominent under this kiddo's hair, and then move down the back. You can see it again as you run your hand over it, you can feel it even better. So the fever, the 3 C's, and rash is sort of our measles diagnostics. And what are the 3 C's? Cough, coryza, conjunctivitis. So you can see the conjunctivitis on this little kiddo, sort of sclera. The whites of the eyes are red and injected. Sometimes they're really squinting and the light just bothers them tremendously. And we don't have time to get into the physiology of that, but that's an important thing to pay attention to. And coryza is just sort of an old-fashioned term, I think, because they wanted 3 C's. It just means runny nose, histamine, that sort of watery eyes, watery nose, goobery looking kiddo. So fever, 3 C's, and rash. And again, most kids present with the first three, but not with this rash. And here's a better picture of up in that kiddo's hairline. You can see where that starts and then moves across the whole body. All right, so this is an important graph here for you. So taking, as you walk through, it's so important as you're documenting a history to be very specific in what the parent is telling you and asking them very specific questions. When was the exposure? What day, what time, what place, who was there? It can help so much down the road for public health, for people trying to figure out whether they're eligible for immune globulin. So those first questions of the family are really, really critical. The incubation period, that is the time from exposure to the time you develop measles, is about 8 to 14 days. Most of our patients were around 2 weeks, a maximum out to 21 days. And then you'll have this prodrome where they start becoming symptomatic. And again, fever, cough, coryza, conjunctivitis looks like every other kid in the ER at that point in time. You are probably not going to be thinking about measles if it's the first case. If it's widely in your community, you should definitely be thinking about it. And so then after that, you may be lucky enough to see these Koplik spots. You can see these kind of white, pearly patches. They're sort of bluish, grayish, whitish. It's hard to see. Sometimes there's only a couple, and it's usually 1 to 2 days before the rash and 1 to 2 days after. You really have to know what you're looking for. And so don't rely too heavily on Koplik spots. It's sort of lucky if you get to see them. And then the rash starts. And so by this time, many kids have been to 2 or 3 or 4 different clinical settings. They've been to urgent care, they've been to primary care, they went to a different urgent care, they come to the emergency room. And so suddenly you've got lots of people in the last 5 days that have been exposed to someone who is infectious for measles. So this 4 to 7 days afterwards, they will develop the rash, and it looks like one of my colleagues used to call it the bucket of measles poured over your head. Literally starts on your head hairline, goes down your chest, down the legs, and importantly, clears the same way. So a parent may say, well, his face a couple days ago was really bad, but now that looks better, but it's worse on his trunk and his belly. Well, they're describing how a measles rash presents itself. So the most important thing is the infectious period when they're contagious to other people is 4 days before the rash and 4 days after the rash. So you have a total of 9 days in there where they're infectious. And it's shocking when you find out, oh, they went to the Mall of America and they were here and here and here, even though they might have been sick, which is another general principle. Stay home when you're sick. And then it can be resolution or complications can be days to weeks to months to years, as I said, with SSPE. But this is why we're talking about this. If measles was just a rash, cold, cough you got over, we probably wouldn't even vaccinate. We probably wouldn't even be talking about this. But it's not. It can be a life threatening disease. And this was a patient of ours at Children's Minnesota in 2011. The mom asked me to take this picture. She said, I just don't think people know how sick you can get from measles and you need to tell people. And I said, well, I'm happy to tell people. And she said, here, take a picture, get the pumps in there, get the IVs in there. And she had taken her 5 kids to the travel clinic to get them all vaccinated so that they could go back to see their grandparents for the first time in Africa. And this little guy had just fallen asleep. He was 9 months old. He would have been eligible for an early travel related MMR. But she said he had just fallen asleep and the clinician really tried to talk her into the importance of it. She said, no, I'll do it as soon as we get home. Well, sure enough, as they were traveling, he got exposed to measles, incubating on the way home, got sick here back in Minnesota. And she said to me, I stand at his bedside, that day when I said no to the vaccine, I regret so much. And, I didn't want to wake him up. And now I just stand here and pray that someday he will wake up. And I think that sort of intense regret and the emotions that parents go through, they don't want to get on a microphone and talk about it. But I think it's important to know how terrifying that is. Thankfully, this child survived. He was on a ventilator for 15 days. His lungs will never be the same, but he did survive. This is why we vaccinate for the severe side effects that can happen. I wanted to make sure you know that there's algorithms out there already. This is a public-facing Children's Minnesota website. If you don't have to reinvent the wheel, we worked really, really hard on this during our 2017 outbreak. Whether you have a measles patient that is symptomatic and you just follow the algorithm on what you do. If they're mildly ill, what tests you do, where you send it, when you start giving vitamin A. If they're moderately or severely ill, the kinds of tests you should do, when you get infectious disease consult involved. And so know that it's very well noted with references and addendums. You're welcome to use that. So vitamin A, let's just talk about that a minute. So during 2011 and 2017 outbreaks in Minnesota, my team was so frustrated with the different language around vitamin A and measles. The WHO said one thing, the CDC said another thing. The AAP Red Book had different language. We're like, should we be using this for all kids? And where or who should get it? And these algorithms that I'm talking about, there's one for vitamin A, one for measles management. You just go to the Children's Minnesota website and put in measles algorithms, and you'll be able to find those. So I was very concerned about, what is the deal with vitamin A? Should we be doing this? Is this for kids in the United States, all kids, hospitalized kids? And so a colleague of mine and I did some research. We looked at all the children's hospital measles admissions for the last 20 years, and it was all over the map. Some kids got vitamin A, some didn't. Those who did get it, almost all of them got very low doses, and it wasn't really that effective. The WHO has been encouraging all children with measles to have vitamin A. It is not a treatment. It is to manage any kind of bad morbidity, mortality, side effects. And so we set out with a grant from the National Foundation for Infectious Disease to write a call to action. And you can get that at nfid.org. It's very detailed on why we give vitamin A, what it does, who needs it, et cetera. So I would encourage you to take a look at that. It is not for prevention. It should never be used to prevent measles by anyone. The only thing that prevents measles is measles, mumps, rubella vaccine. So we developed this vitamin A call to action, and then we put it into an algorithm again at Children's Hospital. But we have some complications with this because the way that these come are in these little gel ampules or capsules. And so for a 1-year-old patient, you can see at the bottom there, it might be up to 20 capsules to get it requires a high dose once a day for 2 days right after diagnosis. So this is post-diagnosis measles management. It's not a treatment. There is no antiviral medicine for measles. There's no treatment for it, but this helps manage some of the severe eye, vision, neurological sort of side effects that come with measles. So we did our measles summit in San Diego, the first part of May here, we did sort of a trial with our pharmacists and actually practice drawing up these 20 capsules and how difficult it was. It's expensive. It takes a lot of time. And it tastes like fish. We tasted it. And like there's so many that kids have to take. Are they really actually even swallowing the whole dose? There is a liquid out there, and it has sort of an orange flavor to it. But people are just getting it off the internet. And we're not sure if it is, been sourced from a manufacturing plant that is certified. It's not FDA approved. So out of the Measles Summit, our pharmacists, there were 3 of them there, are going to be drafting some advocacy papers to go to pharma and ask them to make a more concentrated liquid in a 2-day distribution, the way that it should be done day 1 and day 2 for measles management, because this is very hard to do, although I think it is important to do in the hospital. So all of this that's going on, how do you organize during a measles outbreak? Well, we've used the Hospital Incident Command system, or HICS, and the Hospital Incident Command is a very clear way that you organize yourselves. There's an incident commander, which I have been for most of the last several outbreaks. And then you break it into operations and finance and very, very good about clarifying leadership. It sort of says we're in Hicks, and so this is not business as usual. And requests from the Hicks team kind of, go to the top of the priority list for IT and for communications and for other people in a hospital. It has very clear accountability and really helps internally and externally focus your communications. So I would encourage people to use some sort of way to organize all the work that it takes when you're in a measles outbreak. And then it helps you develop things like this testing and triage grid, like who needs to get tested. So the team would figure it out, and we'd turn it over to the communications people, and they'd make it look pretty, and they would know that this is a priority before anything else that they have. And then we would do things like this, making a testing algorithm. So all of a sudden you've got, oh, we have a measles case, we have another measles case, but everybody has fever, cough, and rash. Should we be testing everybody? And you can see that it's pretty easy to be inclusive. And so we try to make it such that we did some thoughtful analysis of what is their risk factors? Was there a history of travel? Do they have a known exposure? If it's yes, you go to the right there. You look up their MMR status. They have any documented MMR or zero MMR, then it puts them in two risk categories. So you follow it down, you determine their MMR rate, et cetera. So you follow through to help figure out who you vaccinate and who you don't. Again, these algorithms are on that link that was put in the chat. Thank you for that. So the measles confirmed cases, here they were from April, it went all the way to mid-June. But here's the people that also got tested and ruled out. So you're doing a lot of testing to try to figure it out. And that's why having a who do you test sort of grid is helpful. But the main thing is you've got to confirm that diagnosis. I think some of the key infection control points are that we have to be fast, you have to be uncompromising, you have to have multifactorial strategies. You need to have a good relationship between the hospital, clinics, and public health, that public-private partnership. Hopefully, you've already got each other's phone numbers in your cell phone and you know how to call them, because measles has an R0 or infectious rate of 12 to 18 for every one case. We're going to go on and infect another 12 to 18 potentially is beyond normal infection control. That now we need to get into using contact droplet and airborne transmission and N95 masks. And the issue with this virus being so tiny that it can stay aloft and has been measured to stay aloft in usual air exchange rooms for up to 2 hours. In hospital rooms, however, it may be that the air handling is so much better that it's only an hour. And I'm going to talk more about that. That was a big topic of conversation at the Measles Summit. We want to make sure that we've got prevention measures that are going on, vaccination, that your staff are all vaccinated, no exceptions, that you've got rapid ability to get them into isolation quickly. Do you have enough AII rooms? Are you talking with each other, talking with public health, the public? And then using the strategies that we know, which is get that community MMR vaccination rate up. So you're going to have to start doing some pop-up vaccine clinics, making sure that hospitals have enough airborne isolation rooms, rapidly identify people, promptly getting them prophylaxis. If it's less than 72 hours after exposure, they would have MMR vaccine, or if it's within 6 days, they could be given immune globulin. And again, anyone who works in healthcare, clinics, hospitals, it doesn't matter what your job is. If you're in that setting, you should have your 2 doses of MMR vaccine. So we ended up with 745 exposures and gave PEP or post-exposure prophylaxis to 173 people. And this shows you the green dots are positive cases. The blue lines are prior to knowing what the first case was. That was the number of people exposed. And then the dark blue lines are for after the first case of confirmation. And what you want to see is the cases, and that, like you see to the right, where it's just the green dot and no more exposures. So it takes you a few days to get your act together and to set up some of these pre-arrival checklists. For example, on that 5/8 where we had those potential exposures, we revised our ED screening and realized we were emphasizing travel too much, so we took that out entirely. And then had no further exposures after that for weeks. And so but look at public health. So just in that, you can get to these thousands and thousands of people in a very short time. 6 schools were involved, 12 child care centers, and exclusions from school, 649. It really just gets to be quite overwhelming and expensive very quickly. So you've got to identify your exposures. How you do that is with your definition, 4 days before, 4 days after, so that total of 9 days of the day of the rash. And again, what time did the rash start? Where did the rash start? And where were they, like physically? What were they in a public place or at home? Or were they at a school, et cetera? Was AII rooms used, or were they sitting in a clinic lobby that doesn't even have AII rooms, which is very common. Most clinics do not have good air handling. How long were they there? Where was the patient? How did they enter? What rooms did they go by? Were there any, high risk patients that they were around? Looking at their age, their MMR status. You got to figure all this out, and then contacting them. Were there any siblings in tow? Was there a pregnant mom in tow? Does anyone have any immune compromised conditions? You look at their MMR vaccine status, and you can see you really hope that most people have 2 doses of MMR. Then you don't have, then they're not considered exposed. They're considered protected. You send them a letter in the event that there was a newborn baby with them that we didn't know about. But then you're really trying to get out and contacting those with 0 doses of MMR or anyone with any immune compromising condition. And then this is our asymptomatic high risk exposure, how you figure out who gets immune globulin versus MMR. And it really is about timing. And so, that it is the thing that's stressful about measles exposure is the clock is always ticking. So if it's less than 72 hours, you can give them an exposed person an MMR vaccine if they're 6 months of age or older. And if they're younger than that, we watch them. We may also consider IV immune globulin for other high risk patients. So immune globulin would be for those if it's less than 6 days. So there is, again, here's another way to look at it. You really just look at the risk factor on the left column. If it's an infant less than 6 months and it's less than 72 hours, we could give them MIG, immune globulin, and up through day 6. If it's past day 6, then we just wait and watch mostly, because it doesn't have the effectiveness as it does right after. It just is this big immune mop that mops up the viral exposure that is potentially there. There's some susceptible people you want to think about, pregnant women or severely immune compromised. We may go to IVIG more quickly for them, and it's about 400 milligrams per kilogram. And that's not without its problems. I took care of a lot of people with immune deficiencies, and IVIG has its side effects. And it takes a long time, and it's a blood product, and it's expensive, and takes specialized nursing. So we don't want to just say, let's just give everybody IVIG, because it's not quite that easy. So you've got to have lots of helpers. We pulled in the patient safety department, the quality department nurses, nurses that were able to help out from floors that were quiet and had a script. We had interpreters and had to call all these hundreds of people that were potentially exposed and then sending letters to others. You use your ambulatory area differently. So we moved our triage out into the hallway. Are they here to because they're scared and they changed their mind and they want to get MMR vaccine? So you've got healthy, unexposed people that want to get up to date on their MMR. You've got exposed people that are coming in for IMIG. And so we do have options that we will put it together. I see the question about is IVIG an option for infants? Yes, it is versus IMIG. IMIG is hard because it does take so many injections. And so that is a consideration. For sure, that's an option. Universal masking becomes normal. Visitor guidance changes. We have on the left there sort of our normal wellness screening that we always do for patients in children's hospitals across the country. But our summit had a special session just on visitor guidance. So what do we do? What do we do in labor and delivery if, let's say, the partner is incubating measles? We would probably have them, participate in that labor and delivery by way of FaceTime or Zoom and not come to the hospital. So we'll be writing up our recommendations on, no siblings, really trying to make sure that we're doing a good job finding out who's exposed and where they've been. Employee safety, you've got to make sure that everybody is wearing an N95 mask. Yes, 2 doses of MMR is protective, but even with that, sometimes our immune system just cannot handle repeated exposures. Like one of our ER nurses asked to take care of all of these Somali kids, and day after day after day was exposed to these positive patients because he was trying to learn to speak Somali and he wanted to practice. And so there was a lot of talking back and forth and a lot of exposure in the room. And he did end up, even though he had 2 doses of MMR, with a very mild case of measles. And so that's why we make sure that we not only are vaccinated, but also wear an N95 mask. The facility management part is really critical. And this is stuff like make sure you've had these conversations before measles comes to your town. I hope it doesn't. But do you know how to set up temporary AII rooms? If you're all of a sudden your emergency room's overwhelmed, like South Carolina and Utah, you can do this MacGyver business here where you're setting up temporary AII rooms. They're not pretty. They're noisy. They're right in the room with the patient, but they do work, and it does make that particular room negative. So making sure that you talk through how to do that. And certainly there's facilities people that have access to the directions on how to do that, which is posted. There's several places on the internet that you can find out how to do temporary AII. And the other reason hospitals are a little bit more thinking about the 1 hour post-exposure versus 2 hours, there's a lot of sophisticated things that are happening in hospital air handling that no one ever sees. So this is behind the scenes in the basement of Children's Hospital in Minneapolis, which is ultraviolet light. So fresh air comes through and goes through this very large room and is filtered as it enters, is filtered as it exits, and then is zapped by this ultraviolet light as it goes through there. So that's what makes hospital air handling a little bit different to think about than clinics. So we did spend quite a bit of time on this at the summit, sort of this notion of 1 versus 2 hours. And the problem is, like vitamin A, there were different language around exposure definition. CDC said one thing, state health department said a different thing, the World Health Organization had a different thing. And so Dr. Kathleen Harriman, a nurse and PhD epidemiologist, has really spent years looking at this. And she presented and said basically, California has used the 1 hour post exposure in all settings since 2013, and they have had no secondary cases. When we used to use 2 for everybody. So Minnesota has also moved to 1 hour post exposure, and Utah very recently just moved to that as well. And so the original, where did this 2 hours post exposure come from? Because it doubles the amount of work and people exposed. and it came from two physician office settings. And so hospital settings and physician office settings are very, very different. And so we feel comfortable looking at, well, what is the air exchange per hour? And clinics are in this 2 to 4 air ACHs, air changes per hour. And over on the right, if you want to clear the air to a 99.9% efficiency, it's going to take you 207 minutes. Whereas most hospital emergency rooms are down here in the 10 to 12 air exchanges per hour. So you might only need to close off that room for 35 to 41 minutes. And then all of that measles virus that was in that room now has been recirculated back up through the filters, back through that ultraviolet light. And so we feel like we've been sort of over including people with this 2 hours. And the CDC has talked about this as well with using that air exchange chart there. So shorter window of capture versus a longer. The pros are fewer people will be on the contact list to investigate. And I have to tell you, I've had to call so many people and say, your child was in the emergency room and you were sitting next to someone who now has been diagnosed with measles. I'm calling this to a 21-month-old who has leukemia. And the mother is in tears and they're screaming and they're mad. It is a traumatic thing. And then coming in and getting immune globulin shots, the IV, IG, like these things are very traumatic. It's stressful, and it might impact people's trust of us and their ability to come back for future healthcare seeking behavior. So we actually might be causing more harm than good with this 2 hour versus 1 hour business. The cons are like, well, what if we needed to keep it with 2 hours to make sure that we don't miss anybody? But really, if going to 1 hour, it is low but possible that we might be missing a high risk or exposed person. But like I said, California has used the 1 hour post exposure for 13 years and has had no secondary cases. Okay, so hard shift here to communications. A lot of this all depends on how we are talking with families about vaccines. And you know, we have a mountain of vaccine hesitancy, misinformation, disinformation, confusion, and it's a wide range. But I want you to understand the vast majority of parents vaccinate their children on time. They support vaccines, the vast majority. So those who are vaccine hesitant or anti-vaccine are that's a small number, but they're very loud and they're very organized, and their leader is now the administrator in charge of Health and Human Services. And so it's just a very confusing time to be talking about vaccines. But here are some tips from the summit. We really need to meet people where they are. That again, the vast majority will vaccinate their kids, and we need that population of parents to be louder. We want to amplify their voices. So we're looking for ways to get parents who support vaccines to speak up more. Low vaccine rates are not all about hesitancy. We have to look at access issues, schedule issues, catch up. I mean, we told people to stay home during the pandemic, and we're still kind of catching up from that. When low rates are about the lack of trust in vaccines, nothing you're going to do, like a boss or a education plan, is going to help. We're going to have to just really work at that lack of trust business. Social media has been part of the problem that's gotten us into this, but we can use social media for us, not against us. And we have to get smarter about that. We're not as good as people who are using social media to spread misinformation. We want to make sure that we have trust. And our biggest challenge is that trust is not only the problem, but it's an opportunity. We need to turn it around and build trust and make sure that we have people that are trusting us in the vaccine information. Nurses are the #1 trusted profession for decades. We need to make sure that nurses are well educated and confident in how they're talking about vaccines to people. And so I'm very glad you are all here today for this. And then trusted message from trusted messengers. So in our Somali outbreak, I would help the Somali imams and with some of the science background, and then they would go to the mosque and talk to family because I wasn't a trusted messenger. The imams were, and so making sure that we have the right messenger, listen emphatically, things like help me understand how you came to this decision to not vaccinate. Like just be curious, be open, not shaming, not blaming, not judging, building that trust over time. And people will remember what you said. They will not remember what you said, but they will remember how you made them feel. So if they felt heard, or if they felt judged, how they leave will make an impact on their vaccine decisions. So, and then school nurses, as I said, are just a significant part that we have to make sure that we're tapping into. So I'm going to leave you with a checklist. And this is just something that my team developed after going through many of these. These are things that hopefully you can do in advance. Have you hardwired your measles PCR lab order set into the EMR? Do you know your state health department people? Do you have them on speed dial where you can connect with them? Is your organization clear that one case of measles is in fact an emergency? Um, can you easily pull a report on what the MMR vaccine status are of everybody who was in the emergency room last night between 7 p.m. and 11 p.m.? Are you sure that all of your healthcare workers are vaccinated, that it is a condition of employment? So you, in the middle of an outbreak, you're not having to look at the nurses and lab folks, respiratory care, that we know they're already vaccinated because they work here and that's our policy. And so I would just share with lessons learned. Our screening questions sometimes don't always capture it. Every day is a new day, and you just have to make sure that your ongoing vigilance and that the reviewing immunization status early on, even outside of the emergency room in triage, is critical. And making sure that you're rooming those patients into the proper rooms, and outbreaks are very, very expensive. This outbreak was $3 million for Minnesota for those 75 cases, 2 million at Children's Hospital and a million in public health and all of the follow-up work that we did. So there's some reliable resources for you. And we're getting to the top of the hour. I've got some references there for you. Thank my team at Children's. But they want me to do a couple of quick questions for you. You can just answer them in your mind. Which of the following days is someone with measles most infectious? You guys know the answer. That is C, 4 days before and 4 days after the rash. Question 2, vitamin A is used with measles in the US children for prevention, treatment, promotion of the immune response, or management of measles to reduce morbidity and mortality? And the answer is both C and D. So letter E, it is to promote that immune response after the diagnosis and to manage the measles morbidity and mortality. And then the last one is, what stops a measles outbreak? How do we get out of this? Well, all of the above. We need high community MMR vaccination rate, immediate airborne isolation, rapid identification, prompt post-exposure prophylaxis, frontline worker vaccination rates. So thank you so much. I've got 2 minutes for questions here, Dr. Newman. I'll turn it back to you. Thanks for having me.
Wow, thank you so much, Patsy. We actually had a comment I think is worth reading. It says, phenomenal presentation. So nice to have a presenter with real world experience, not just someone reading slides. So I
Oh,
would echo that. Thank you so much for just your wealth of knowledge. Oh, yes. So I know we're almost at the top of the hour. For those that need to leave at 1, we understand. Maybe we'll just answer a couple of questions for the sake of the recording, if that's okay with you, Patsy. We had a few.
sure, sure.
Um, First, someone said, how do we, the medical community, combat the strong political influence, which contributes greatly to the high unvaccination rates in so many states, like you showed us?
Yeah. Well, that's a huge question, and it is a true statement that you can look at who voted, voting red states and blue states, and red states have lower vaccination rates, higher incidences of measles outbreaks, higher incidence of COVID. And so this is very unfortunate that vaccination has been coupled with a political platform, a conservative political platform. And I think the best we can do is what we're doing today is just show the consequences, tell the stories of parents that were like, I did not know that you could be this sick on a ventilator in the hospital. I think we need to make sure that people who support vaccines, we don't want to tie it to a political platform, but I think we want to talk about it more broadly in systems. Like we need affordable health care. We need schools to be a supportive place and public health measures. We need to build our public health infrastructure to have trust, et cetera. And I'm just very sorry I have this much experience with measles. I wish I didn't, but I'm happy to share. And I think we need to all make sure that we know that prevention is not glamorous or glorious. Like you do all this vaccination and nothing happens. And so that's what we have to invest in is prevention.
Yeah, I could, as a pediatrician, I could not agree more with all of those sentiments. Beautifully
And
said.
God bless you for doing that. This time is just so hard with the
Yeah.
internet and social media.
Maybe just one more here. Someone asked, do vaccinated children have a less chance of getting SSPE even if they catch measles?
Yes, absolutely. So, um, SSPE would follow someone who had a severe case of measles, especially in the first year of life, who had no antibody protection. So, a vaccinated person, even a single dose, would be substantially preventative for that. So, someone who has two doses, who still gets measles, would not have the kind of severe case that would cause SSPE.
Okay, well, there's a few more, maybe one more. Someone said, I think this is an important one. I'm a mom of a 4-month-old, and I personally worry about my infant contracting measles. Do you have any recommendations for families on how to protect infants who are too young to be vaccinated yet?
Yeah, that's a hard one. And we don't vaccinate at that age because maternal antibodies are still there. And if you give a live vaccine, those mom's antibodies will blunt it and not let that baby take it in and make them as permanent antibody memory. So I think one, be very aware of what's happening in your community. As you saw, like I started with the country map and then the state map, and it's really down to what is happening in your county. So look at your state health department's website, your local counties, making sure that you're aware of what's going on in your city and state. I would say, like, if you're having people over, like, is everybody healthy? That's normal to me. When you have a young infant, anyone with a cough or cold should probably stay home, certainly stay home with the fever. Um, if you're going on any kind of travel, and I don't even say international travel anymore because airports are typically international and people are coming and going from all over the place, is to have a conversation with your clinician about whether or not your child should have an early vaccine. We typically do that up 6 months and above. Although, listen for your state health department people. Sometimes they will say that there's so much measles that anyone and everyone, travel or no travel, could get an early one. So you would get that early dose at say 6 months, and then another one at 12 months, and then your kindergarten. So it's basically an earlier protective dose. But I think, it's our job as parents to be protective and assessing who's coming into your home and whether they're sick or the kinds of places that you're going. If there's going to be sick people or big crowds, try to avoid that if you can. It's hard, and I'm with you as a parent. I'm a mom of two girls.
Really great information. Well, thank you, Patty, and thank you everyone for joining us today. We look forward to seeing you again at our next webinar.
Thank you, everyone.